control ventilation. Got it? And then peripheral chemoreceptors, they're called oxygen-sensitive cells that react to the reduction of oxygen levels in the arterial blood, meaning the PaO2, 60 millimeters of mercury or less. That's when they're activated. Okay, and turn to page 372. Look at the paragraph. It's 1-2. It says, as shown in figure 9-6. Everybody with me? Mm-hmm. On page 374, the peripheral chemoreceptors are not significantly activated until the FiO2 is low enough to reduce the PaO2 of 60 millimeters of mercury. I'm not making this up. It's right here in the book. Because I know some of you are visual. Here it is. See it? Yes. Mm-hmm. Everybody see where I am? Yeah. All right. So the peripheral chemoreceptors are activated when the PO2 is 60 or less. It doesn't have anything to do with hemoglobin saturation. We don't know why, but it's a phenomenon. We know oxygen is carried two ways. When a PO2 reaches 60, it's still insignificant, but the body reacts. So peripheral chemoreceptors doesn't have anything to do with the 98%. It's only dealing with the 2%, the PaO2. It is activated at 60 or less, and those responses in order, your heart rate will increase, number 1. Then the person will become tachypnic, number 2. Number 3, as I had on the PowerPoint, pulmonary vasoconstriction. And then if it gets bad enough, the patient will become diaphoretic, cool and clammy to touch. Got it? All right, the next paragraph, it says, in the patient with a low PaO2 and a chronically high PCO2, this is the CO2 retainer that I was talking about. The last paragraph, everybody see it? This is a CO2 retainer. Not all COPD patients, I want to make this clear and let me know if I'm going too fast. Not all COPD patients are CO2 retainers. Not all. But those that begin to chronically retain CO2, probably from cigarette smoking, I'll just make that the culprit. Cigarette smoking, if they have high PaCO2s, their central chemoreceptors are knocked out, and all they have are their peripheral chemoreceptors. And this is what this paragraph is saying. In patients with a low PaO2 and chronically high PaCO2, like end-stage emphysema, I refer to it as stage 3 and 4. Same thing. From a PFT perspective, a pulmonologist will say it's stage 3 or 4. End stage means terminal, stage 4. No more. Okay? It says the peripheral chemoreceptors may be totally responsible for a patient ventilating. That's all they have. And if we give them too much oxygen and raise their PO2 above 60, we knock out the hypoxic driver, we knock out the peripheral chemoreceptors, and consequently, it can cause death. Okay? Here it is. The book may not say it exactly like I'm saying it, but I'm expounding upon what your text is saying. So for those that are visual and you need to read it, it's right here. Control of ventilation. Any questions? Any questions with this? Yes.
It says over here that it's important to understand that peripheral chemoreceptors are specifically sensitive to PO2 of the blood and relatively insensitive to oxygen content of the blood.
That's what I said. It's relative to PO2. It doesn't have anything to do with hemoglobin saturation of oxygen. That's what I said. Yeah. So it's only the PO2. It's only peripheral chemoreceptors only respond to the 2%. And it makes sense because you still are, you probably still, even if your PO2 is low for most patients, other than the COPD patient, for us, we still have 98% of our hemoglobin saturated with oxygen, so that 2% is insignificant. It's indicating something is beginning to go on, but the body is still receiving adequate oxygen through hemoglobin. Okay? So I want you to understand peripheral chemoreceptors only have to do with PaO2. Okay? All right. Turn to page 377, and this is where I want you to see why you need to know these synonymous terms. Page 377, clinical connection 9-4 at the bottom. It says the hazards of oxygen therapy in patients with chronic hypercapnia. What is chronic?
Long-term.
Long-term. Hypercapnia. What is hypercapnia? Too much CO2. A patient is retaining CO2. So chronic hypercapnia is the same thing as saying compensated respiratory acidosis. This is why you need to know these terms. Most students think this is Kathy Miller trying to project her intelligence. I'm preparing you for the profession of respiratory care. I know what I know, and I know that I know, and that I don't know, I don't know. But I know what I'm doing, and here it is. Chronic hypercapnia is the same thing as compensated respiratory acidosis, and you need to know this. It depends on the author, and here it is, right here, so you can read it. It says in some patients with chronic hypercapnia, hypercapnia is chronically higher normal than PaCO2 levels. And we just learned about a CO2 retainer, right? So this is talking about a CO2 retainer. They have high CO2 levels. Their central chemoreceptors are knocked out. So all they have are their peripheral chemoreceptors, or what we call the hypoxic drive. Yes? Yeah. All right. It says, and hypoxemia, example COPD. I told you that. The administration of too much oxygen may suppress the peripheral chemoreceptors and depress their ventilation. So when we give a CO2 retainer too much oxygen, we knock out their hypoxic drive, or we deactivate their peripheral chemoreceptors, and they stop breathing. Any questions? Everybody got it? I'll give you a few minutes to absorb that. Respiratory therapists know this. Yes, you'll be tested on it, but you have to understand, if you have a CO2 retainer, you cannot give them too much oxygen because they're not breathing off their central chemoreceptors. And you need to be able to articulate this. Tell anybody what central chemoreceptors are and what peripheral chemoreceptors are and what they mean. So when we say chronically hypoxemic, CO2 retainers will always be chronically hypoxemic because they don't have central chemoreceptors to breathe off of. All they have are peripheral chemoreceptors, and you now understand peripheral chemoreceptors are only activated at a PO2 of 60. So you could have a CO2 retainer with a PCO2 in the 80s and 90s, and that's normal for them. It would kill us, but that's normal for them, and maybe their PO2 is only 57, 58. We can't be so eager and give oxygen to the rescue. We'll kill them. So we only give them a nasal cannula, 1 or 2 liters per minute. Can't give them any more because it'll do more harm than good. Understand? All right. Are there any questions? Can I clarify anything for you?
A doctor is the one that will tell you that they're a CO2 retainer.
No, you can read the chart.
Oh, okay. That's what I meant then,
You can
too.
look at the blood
Okay,
gases. You
but
don't need a doctor to tell you that. You can look at the blood gas. Well, this is mixed acidosis. I don't have anything up here. This one, I would probably change this pH, but I probably think of that one as being a CO2 retainer. Here's one. I know this is a CO2 retainer.
okay.
Because this, I know it's a compensated blood gas. It took time for the kidneys to kick in, and this PCO2 so high, I would expect to see a low PO2 with this. And I know this is chronic hypercapnia, and I know this is compensated respiratory acidosis, just by that.
Okay.
I don't need a physician to tell me what this is. I know what this is. Actually, you should be telling the physician. I don't understand. Why is this patient's blood? You should be able to tell them why. Make sense? Yes. Yes, ma'am.
So with compensated respiratory alkalosis, could you call that chronic hypo?
No, ma'am.
No?
No, ma'am. No such thing.
Okay.
No, ma'am. Don't cross wires here. No. But good question, but no.
Okay.
There is no compensation. I mean, you may have a patient in that state, but there is no chronic hyperventilation.
Okay.
Hyperventilation is always acute.
Okay.
So if you see a normal pH and you see hyperventilation, the hyperventilation is compensating for metabolic alkalosis. I'm sorry, metabolic acidosis.
Okay.
You following me?
Yeah.
You sure?
Yes.
Okay. All right, any other questions? Here it is. If you need to study it, here it is. Peripheral chemoreceptors and central chemoreceptors. Okay. Chapter 9, I just wanted to provide you with that. It may be in Egan's, but this, for me, this is easier to read. Is it in Egan's? I very seldom. Okay. Any questions with these blood gases? Anybody have any questions with these blood gases? If you don't have questions, that means to me you understand and I'm moving on. Interpret the blood gas. Any questions?
I have one.
Yes, ma'am.
When everything is in your blood gas all acid or all base, can you tell me again why it's not compensated or uncompensated?
If everything is acid or all base, that means the pH is not within normal range, so it's not a compensated blood gas.
Okay, thank you.
Yeah. And remember that little free-floating hydrogen ion? It determines what's going on. And so the whole ideal of compensation is to have that pH within normal range. But if the pH is not within normal range, it's an uncompensated blood gas. Meaning whatever the primary problem is, the other part of that, whether if the primary problem is lungs, the kidneys haven't had time to kick in, or if the primary problem is kidneys, the lungs haven't had time to kick in to try to regulate that pH.
Okay, thanks.
And that takes time. Yes. Any other questions? All right, I'm going to take it a step further. Everybody can do this?
Yes.
All right. We're moving on now. It's another step we're going to get the blood. This is not all of it. I'm just gonna move this blood gas over. That's all I'm doing, so you don't have to write this over. I'm just gonna move it over. Okay. And make it 3. Difference between these blood gases, this is, somebody tell me what this is. This is acid,
Yes.
that's acid, that's normal, that's normal. So what's the primary problem? Lungs or respiratory, so we're calling it respiratory acidosis,
Acidosis.
right? And it's an acute situation. You can either say acute respiratory acidosis or uncompensated respiratory acidosis, right?
Right.
Whatever floats your boat, either is correct, all right? This one, this is normal. Here I see acid, here I see base,
Base.
and this is base. So I have 3 things going on. I have an acid condition and a base condition, but I have a normal pH, right? So I know automatically, just looking at this pH, that the blood gas is compensated, right?
Right.
I have to find what was the original problem. Yes?
Yes.
So my pH is on the acid side of normal. So then I know this is compensated respiratory acidosis or chronic respiratory acidosis. Everybody with me?
Yeah.
You all got that?
Yes.
All right, here we go. In between. This is what I'm doing for number 2 happens in between this and this. And I'm going to kind of keep the numbers the same so you can see where I'm going with this. Okay. We know this is uncompensated. That fact is established, right? We know that this is truly a compensated blood gas, right?
Right.
Okay, now the patient comes in and we didn't see the first blood gas. We didn't see it. Meaning that when the patient came in, they were beyond that. So now here's the second blood gas. And this is contrary to everything that I've taught you, but it's a step in between. All right. So here's my pH, and it is what? Acid or base?
Acid.
Okay. And here's my PCO2, and is it acid, base, or normal?
Acid.
All right. Now, I got a bicarb. Is it acid, base, or normal? Base.
Base.
It's base.
Yeah. 26
That was
28.
normal. No attempt of compensation at all. The kidneys haven't had time to kick in. So this why this is an acute situation. Make sense?
Mm-hmm.
This is still acute because my pH is not within normal range. Right? All right. But now I'm beginning to see, I see some base here, and I see this is base. Well, I know it's not completely compensated because that pH is not within normal range. Everybody see that?
Yes.
What's my primary problem?
Respiratory.
Respiratory acidosis.
Doses.
But this blood gas is partially compensated. Write it down.
Partially compensated respiratory acidosis.
Yes, sir. Partially compensated respiratory acidosis. How do I know? Well, I see my primary problem, acid. But if I compare these numbers to that number, I know this is totally uncompensated because the kidneys haven't kicked in, right? Now here, the kidneys have kicked in and they become alkalotic. Why? By this bicarb raising from normal up to 28, it's bringing the pH, it brought the pH from 7.27 to 7.29. And then when it completely compensates, the bicarb elevated again, and it brought the pH from 7.29 to 7.36. So we may catch a blood gas where compensation has begun, but it hasn't been completed. But nevertheless, we can still identify the primary problem based on what matches the pH, and then the other condition, metabolic here, is opposite, it's base. But it hasn't become basic enough, or alkalotic, rather, I like that word better. It hasn't become alkalotic enough to push the pH up to normal. It's going to take time. But when it does, then the pH, the bicarb in this case, rose to 31, and it brought the pH to 7.36. This is called partially compensated. Yes, ma'am.
What's the difference between partially compensated and acidosis? Just the
A big
comparison.
difference.
The comparison.
Acidosis, this would be acid, below normal. Big difference.
How can you differentiate between something if you just had one blood gas, if you just saw one blood gas, how could you see how it,
I don't need this.
the pH is acidic?
Look at the pH. pH is acidic.
I don't need this. I still can call this partially compensated. I see my primary problem, and this is opposite. This is acid, this is base. The pH is not within normal range. I know it's partially compensated.
Okay.
You got two different conditions going on here. But a pH is not within normal range, and I know it's partially compensated. Okay, I'll do another one. I'm gonna try, no, I won't use the same number. No, I don't want to do 5-0. I'll do 3-0.
Oh,
So sorry.
I got a raise.
Yeah, you do. All right. So our pH is what? Out of range. Yes?
Yes.
So it's acid. My PCO2 is acid, base, or normal?
Base.
Base. It's not barely. Normal is 35. This is 27. It's a difference. And bicarb is 16.
Acid.
Acid. So what's my primary problem? Metabolic acidosis. But this PCO2 is not normal.
Right.
If it were normal, I would call this blood gas in totality, completely, uncompensated metabolic acidosis, right?
Right.
But this the PCO2, the lungs have kicked in and started hyperventilating, yes? So this blood gas is partially compensated metabolic acidosis. If it was uncompensated, I would see this. I'll just put it on the board. Same numbers, but my PCO2 would be normal.
Right.
Now that's uncompensated metabolic acidosis, because this is acid, and this is normal, right? And remember I told you the kidneys will kick in within 72 hours and attempt to compensate. The lungs will kick in within 12 hours. So this was our primary blood gas, and I saw a metabolic acidosis. I'm just using numbers. 10 hours later, now I see my lungs, I see my patient, you can't see, but based on the blood gas, patient is hyperventilating. Why? Because as the patient hyperventilates, as this becomes base or alkalotic, it's going to push the pH up within normal range. So complete compensation hasn't occurred yet. How do I know that? Because my pH is not within normal range. But I know some compensation has begun to occur because I see two opposite conditions here. One is buffing the other. Which is buffing? Well, this is my primary problem. So the lungs have kicked in and begin to hyperventilate to blow off CO2 and retain hydrogen ions, and consequently it'll take the pH up over a period of time, and then we should have a compensated a metabolic acidosis, but right now we don't. Yes.
I'm starting to understand this a little bit better. I've been looking at, like you said, about 20 minutes every day. One thing that's throwing me is the BE, the bicarb excess. Now, when you said we can leave the bicarb excess blank on a few of those last
Base
week,
excess, yes.
or base excess blank, that was really throwing me, because I didn't know what number to throw in there. I mean, am I missing something here?
Yeah, you're missing it. Base excess is an index, a window to the bicarb. If the bicarb is acid, the base excess is acid. If the bicarb is normal, the base excess is normal. If the bicarb is alkalotic, the base excess is alkalotic.
All right, so that BE is always going to match that HCO3.
Always.
So when one's acid, the other's going to be acid, and
it's a window that we can get. We can get a base excess. I don't want to go into detail, but it's called a chem panel, and it measures electrolytes, fluid and electrolytes, and anion gap. We're going to learn about the anion gap and a base excess. You can see a base excess, and it won't give you a complete interpretation of a blood gas, but as a therapist, you can look at the base excess and determine the status of the kidneys. So if I see in fluid and electrolytes, if I see a base excess of 5.2, I don't need a blood gas. I can't interpret the blood gas completely, but I know that this patient is in metabolic alkalosis.
Yep.
Just based on that number.
because if that's high, which it is, that's on the
Alkalotic
base side.
Absolutely.
So that means that his, without even seeing that, I know that his HCO3 is going to be base.
Absolutely. That's
So
it.
no matter what's going on with his acid, I know that this guy is base.
We can't see the big picture. We don't know the pH. We don't know the PCO2. And it could just be from drugs. But nevertheless, I know just looking at a base excess, I see metabolic alkalosis. And that's what a therapist can do.
So when you said we could write a number in there, when you left the BE open, you said
I
just
wanted
put a
you
number.
to write a number to match the bicarb.
So it didn't matter. I mean, as long if the bicarb was showing base, as long as I wrote a number in the base excess, it was on the base side, I was good to go.
When, this really brings a big question in my mind anyway. When your body is trying to compensate and bring the pH to normal, let's say the CO2 is off base, it's on base side, and your kidneys are trying to bring it up, will it continue to do so until it brings that pH back, or is it possible
No.
to fail?
No, not always. Sometimes people die before it happens. It depends. See, like in this case, if the patient's in metabolic acidosis, this is fine if the lungs are healthy. But if the lungs are not healthy, it's not going to happen. And the patient will be in trouble. The patient will be in respiratory distress, and we got to help them and put them on a mechanical ventilator. Okay? So a lot of pathophysiology is involved in this, but we got to get to that point to make that determination. You must understand this before we do patient assessment. And you say, why is the patient on the ventilator? Well, the patient's on the ventilator because his lungs are trying to compensate for this problem, and based on a chronic pulmonary interstitial fibrosis, it can't do it. So they have to go on a ventilator. Yeah. No, so full compensation doesn't always occur. Sometimes patients die before it happens because the body will go into shock or the body breaks down, multi-organ failure, and it's not going to happen. But if you do see it, you know what to call it. Okay, and some of these can be caused by medication. Medication will cause a metabolic alkalosis. Okay, everybody see what I did, partially compensated? Do I need to put another one on the board?
Yes.
So you
Yes.
got uncompensated. That's why I've been giving you so much every week. This is, we got more to go. More to go. And then we're going to take all this and relate it to patient assessment. And it takes more than a module to learn blood gases.
Can I throw myself to the wolves here and do one?
You going to let them eat you up?
Oh, yeah, absolutely. I mean, I gotta learn it. So if you throw one, if you put a couple up there, may I do one?
Absolutely. In other words, you'd like for me to challenge?
Absolutely.
Yeah.
I mean, I'm not polishing the apple here, but yeah, I mean, I'm having a hard time.
I had a thought, but I'm gonna keep it. I'm not gonna go there. I think we're all with you.
Look, I know you're a Jedi. I'm not gonna mess with you. All right?
I'm gonna leave that one alone. That's why I said every day, I know you may have quizzes, I don't care. You gotta sacrifice. Because it's gonna come to a point, and Miss Sharkana is not gonna test you, I am. I'm gonna test you. As long as I'm program director, I control blood gases in this program. That's the only thing I take reign on. Anything else, they can have, but I have to make sure. And I'm not saying that no one else can do it. I'm not implying that. I'm not implying that, but as long as I am program director, I teach blood gases.
Now, did you say it was not common in other programs to teach blood gases this early?
Yep. I don't care.
No, I like it.
Then it just looks like a step up.
When you go to clinical,
Yeah.
you may not be completely ready, but if someone shows you a blood gas, you may not tell them this, that, and the other, but you can interpret the blood gas. And then if you have this fundamental or base knowledge, when you get to clinical, you can build upon it.
I think it helps us with the other terms too. You'd be speaking very fast.
Yeah.
Absolutely. Okay, so we know this is pH, and remember now, we haven't added oxygenation to this yet. We're just dealing with acid-base balance. But after Module 2 in Monday and Wednesday class, I'm going to put oxygenation in it then too. Okay, here we go. I'm going up higher. Okay, come on, Kyle. Do number 1 and do number 4 while you're up there. Right, so what are you gonna call it? Absolute. Who wants to come do number 2? Come do 2. You want to do 3? Who wants to do 5? Mendelson,
Yes, ma'am.
was it another marker up there for you? No? Here, let me see. Oh, okay, thank you. Ebony? Jennifer? Michael? Rachel, here, I have your quiz. Barbara? Amy? I want to make sure I don't give you someone else. Kelly? Oh, Kyle, right here. Jonathan? Heather? Catherine?
I know, I understand. I see the metabolic alkalosis.
Yeah.
All right, so pH would have went to normal.
That would be.
Partially. Or that would
No,
have been uncompensated.
Yeah.
Thanks.
You were. Oh my gosh. Oh, I'll pass it over. Okay, let's go through these. Kyle says the pH is 7.24. Everybody agree? Number 1?
Yes.
All right, PCO2, he said is acid, yes?
Yes.
So we know the patient is hypoventilating, and the bicarb is 30, and the base excess is 4, which are both base. So we have 2 conditions going on. We have something acid, we have acidic lungs and base kidneys. However, the pH is not within normal range. So we know the primary problem is respiratory acidosis, but because the bicarb and base excess are elevated, making it a base, he's got partially compensated respiratory acidosis. Is he correct?
Yes.
Yes, he is. Good. Okay, number 2. The pH is acid. Is that correct? The bicarb, I'm sorry, the PCO2, the patient is hyperventilating, base. The bicarb is acid and the base excess is acid. So I know the primary problem is metabolic acidosis, but I see an opposite condition, base here, and I know that the lungs are hyperventilating, trying to bring this pH within normal range, almost, but not there yet. So then I know it's partially compensated metabolic acidosis. So is this correct?
Yes.
Yes, it is. All right. I have here a normal pH. I have alkalitic PCO2. The patient's hyperventilating. I have acid kidneys. So I know this is a compensated blood gas because I have 3 things. I have a normal pH. I have alkalitic lungs, and I have, alkalitic lungs, and I have acid kidneys, metabolic, right? So I go back up to my pH, and is it on the acid side of normal or the base side of normal? It's on the base side of normal. So my primary problem was hyperventilation or respiratory alkalosis, but because the kidneys have kicked in to buff that pH, it is now compensated respiratory alkalosis, right? Okay. Very good. pH is base, PCO2 is acid, patient really hypoventilating. Bicarb is base, and base excess is base. But I see I have 2 conditions. I have acid lungs, and I have base kidneys, and I see that my pH is matching the base kidneys. So I know my primary problem was a metabolic alkalosis, but because I have lungs that have begun to hypoventilate or that are acidic, this is partially compensated metabolic alkalosis. Agree?
Yes.
Any questions with this? All right. All right, and over here I have a pH that's normal. I have acid lungs, and I have base kidneys, and I have a normal pH, so I got 3 things, normal pH and 2 opposite acid base. Which one is matching the pH? Well, the pH is on the alkalitic side of normal, so it's base, so the pH is matching the bicarb, so I know my primary problem was metabolic alkalosis, but that pH is normal, so this is compensated metabolic alkalosis. Any questions? Okay, you'll see it tomorrow on your quiz. All right, I'll leave it up there.
All right.
Yes?
I didn't get my quiz then.
How come?
I don't know, but there's a grade in Blackboard for it.
Eric, I just wanted to see if you were on your toes. Here it is.
I didn't either.
Amanda? I gave you yours the other day.
I'm all over the map.
Amanda?
Ganya.
Ganya.
That's right.
Somebody, come get this quiz. There you go. Okay, everybody got their quiz now? Yes.
Are we going to be able to use note cards for that acid-base test tomorrow?
Absolutely not. I expect more of you. How about that?
Yes.
Miss Miller?
Yes.
My Blackboard is a different grade for quiz number 2.
Give it back to me. Okay. I could have transposed it. I'm gonna just give it back to me.
Thank you.
Okay, so much for blood gases, so much for peripheral chemoreceptor, central chemoreceptor. Now, before I move on, any questions? It's more to come with blood gases. We're not halfway there yet, but we'll get there. I'm just giving you bits and bits and bits. Like I said, you can go to Egan's And your choice, I don't know, I think it's chapter 13 or 14, I'm not sure. And in your cardiopulmonary A and P, acid-base balances, I believe, chapter 7. Yeah, chapter 7. You can read it if you want. I just don't want you to get confused. So if you can do that. Also, what you can start doing, not in this class, but RSC 201, go to the external links, and I have the ABG tutor. You may or may not be able to use it because I haven't given you oxygenation yet. But far as acid-base balance, uncompensated, partially compensated, or compensated, you should be able to do it. Get together as a group, pairs, partners, make up blood gases, quiz each other. You don't have to do it alone. Do what you have to do to learn it. You got to know it. And the more you do it, the more efficient you become in it. Yes?
Well, after at 12:40, I'm going to be in the library at 1 o'clock. If anybody wants to go over blood gases, come on down.
No, we have one meeting today.
We have your meeting.
What meeting today? What time is that? Is that over?
At 2:30.
All right, so,
Doesn't mean you have to stay to 2:30, but they're going to go from 12:30 to 2:30.
at 2 o'clock, I'm going to be in the library, if anybody wants to go over this stuff.
I know you all have a class Facebook page. Put some blood gases out there. Anybody want to do them, do them. You've got to do this. I'm giving you the fundamentals. And I know some of you visual. My second-year students had a big-time problem with Kathy Miller because don't get me wrong, I have nothing against text. Nothing against it. And they had a problem because I didn't use the book. When I started using the book, then they asked me to go back. No, we're going to use the book. And so I don't want to start you out confusing you. I take everything in the text and break it down, make it applicable so you can get right to it. Because these authors are good, but they like to add a lot of fluff. You don't need all that. Let's interpret the blood gas. Let's do it, and you can do it. So the more you do it, the more proficient you become. Don't wait till I come in here and you come in here and you see blood gases on the board to practice. It's not going to work, and it's going to catch up with you. Particularly next semester, even this semester, I'm going to start talking about diseases. And I'm going to expect you to give me a blood gas based on clinical manifestations. So if I say your patient is a CO2 retainer, you need to provide me a blood gas for a CO2 retainer. You need to be able to do it. And so that's why I keep doing and I chip away each time. Okay? All right. So if you have questions, every day I come in and I ask you if you have questions. If I don't answer your question to where you completely understand, you need to see me. And it's your decision. All right, let's move on to pharmacology. You have your drugs for this week. You have your drugs that you are researching, your individual drugs. If you need help or questions with that, someone asked me this morning about your drug cards and special instructions. For your short-term and long-term beta-2 agonists, it probably won't be any special instructions, but particularly when you get to those corticosteroids, you'll have special instructions. So special instructions won't apply to every drug, but just to give you an answer, not an answer, give you an example. Is it Asmacort? I think with Asmacort, it has an inhaled corticosteroid in it. What you have to do is make sure to instruct your patient after they use this drug, they need to brush their teeth. That's special instruction. So every drug won't have special instructions, but some will, particularly those corticosteroids. All right? Everybody clear with that? Okay, so don't make up stuff. If it's no special instructions, don't you make up any. But if they need to rinse their mouth out or brush their teeth, or make sure, if it says make sure that the patient doesn't swallow it, those are special instructions.
Stuff like cheese pizza after ingestion won't cut it then.
Right. And you know what? Statistics show, facts show in respiratory care that the drugs that we administer, when I say administer, I mean the drugs that are administered, they're only about 27% effective. And research has been done, and why is it only 27% effective? It's not because of the drug, it's poor patient instruction. That's why they're not effective. Because doctors just may write an order, and nobody has instructed the patient how to take the therapy, and everybody is not going to go home and open the box and read the label. And if they do read the label, it's going to be medical terminology. They're going to be intimidated when they see words by hypersensitivity. What does that mean? They're going to see beta-2 agonist or sympathomimetic. It means nothing to them. So they're not going to effectively know how to take the drug. And so that's why it's important that we as respiratory therapists, either on the back end of the patient going home, or home care therapists, or in pulmonary rehab, or wherever we are, to instruct patients to take the drugs thoroughly. If it's a small volume nebulizer, we do that right there. We can supervise them. No problem. But when they go home, the drug isn't working. Why? Because they don't know how to take it. And let there be light. Eventually. Just a few things really that I want you to know. Yeah. Okay, I think I left off here, didn't I? We did? This is how the forms that we use, the vaporizer as a humidifier, atomizer is rarely used today. Most is small volume nebulizer or large volume nebulizer if we're going to administer the treatment, ER, floor, intensive care unit, or whatever. And then meter dose inhaler, the diagram that I gave you, that Mendelsohn has up, all these are MDIs and DPIs. And this is where we have found, or research has found, statistics indicate that these medications overall have only been 27% effective because the patients don't know how to take it because they haven't received instructions. That's why these drugs are not effective. And so we have to educate the patient. So this is MDI, DPI. You're going to find some of your drugs, as albuterol, will come in aerosolized. Your drug cards or your text may say aerosolized. When something is aerosolized, that means we administer via small volume nebulizer. It can be MDI or DPI. You need to know, because on your boards they'll ask you crazy things, and they're not asking you to trade name a generic name. They'll give you that. And they want to know, do you know whether a drug is MDI or DPI? And they'll ask you, they'll give you some crazy answer, and you need to know the difference. And we're going to go through that, but not yet. Okay? Any questions for this? All right. You know about the pharmacokinetic phase, how a drug is absorbed, is distributed, metabolized. It's called first pass effect, and eliminated. And if a drug is eliminated through the kidneys, it's metabolic or urine. And if a drug is eliminated through the lungs, we know we call it respiratory, and it's going to be exhaled. Right? Yeah. Okay. That's all I want you to know. That's all I need. Okay. Pharmacokinetic phase. Local versus systemic. When we administer our drugs, we're administering our drugs via inhalation, and that's local, and it's good. We know enterally that is easy for most patients, not babies. But it's easy to take a pill, right? It's easy to swallow a pill. But could you imagine someone coming through the emergency department and they're asthmatic and experiencing bronchospasms, and we just give them 2 pills? It may take a while for that pill to be distributed and metabolized, right? So when a patient's in distress, or even if they're not in distress, we'll administer our drugs locally via inhalation. And it's advantages to that. And the first advantage is that the drug is distributed faster because they're inhaling it, and we want it to get, particularly in those large airways. Okay? And just a little pathophysiology, I'm not going to test you on it. Most adults that wheeze, it originates in the large airway, the bronchi. And for most children that wheeze, it originates in the bronchioles. And when we administer a drug locally or via inhalation, the drug is distributed faster. It gets to those bronchi a lot faster. It has a quicker onset, meaning the drug is effective a lot sooner, as opposed to taking a pill, right? Now, there are some drugs we have to take orally, which is good, but it takes time to get in your system. So let's talk about maybe you're taking antibiotics for 10 days, as opposed to you having an asthma attack and wheezing. You need something that's going to get to the lungs right now to help minimize the wheezing. It may not stop all of it, but at least you will feel better, right? Okay. So it's quicker onset, meaning the drug is going to be more effective and has fewer side effects. Now, that's a great advantage because if a drug, easy route of administration is oral. But we have to remember, whenever we take medication orally, it's going everywhere. And it can be greater side effects to it. But when we administer our drugs locally via inhalation, it's fewer side effects. So it means that the drug has less side effects on our particular organs. And so it's a great advantage. There are some disadvantages, but it's a greater advantage. So someone's in distress, and someone like asthma that's having bronchospasms, we've discussed, and I know you learned it in cardiopulmonary A&P, about the diaphragm. We've discussed that, and I want to let you know that a function of the diaphragm is to separate the thoracic cavity from the abdominal cavity. That is a function of the diaphragm. Because when you cough and you didn't have your diaphragm, your intestines would come up in your chest. Okay, so a function of the diaphragm is to separate the thoracic and abdominal cavity. I just want to provide clarity. All right, so we have fewer side effects. And we have fewer side effects because we have side effects, but they're less side effects because it's not going systemically. All right, so that's a great advantage, local versus systemic effect. That's good. Inhaled aerosols, SVN, aerosol and pulmonary disease, good for bronchial smooth dilation. What's another name for that? Bronchial smooth dilation. Bronchodilation. Via beta-2 agonist, right? All right. And airway clearance of secretions. Why are we concerned about a productive cough? Because what do excessive secretions in the airway, what can it potentially do? Cause a patient to wheeze. So we give a beta-2 agonist to reverse the bronchospasms, whether it be mast cell degranulation, whether it be airway clearance of secretions, or caused by secretions. That's why we give it. So when we administer these drugs, we want to see, as I mentioned last week, if the patient can have a productive cough. They may not be able to, but we want to facilitate a productive cough. In my own definition, this is not in a book, and I'm not expecting you to agree with me, but I just want, in my own mind of respiratory care is maintaining and protecting a patent airway. And when a patient has excessive secretions, it is not a patent airway. Does that make sense? So we have to do whatever means necessary, help facilitate if the person can cough. Some people can't cough, then you have to intervene. But if a person can cough, we have to facilitate and encourage them. And sometimes it's painful because maybe they've had thoracic surgery or maybe they've had abdominal surgery. And it hurts. But nevertheless, if they don't try to cough, potentially the lungs can go atelectic. And when I say atelectic, what do I mean? What's atelectasis?
Collapse.
Collapse.
Lungs collapse.
Yeah, collapse. The lungs will collapse. Does that make sense?
Mm-hmm.
All right. All alveoli are not equal in size. And so when we don't take some time, I say you're going to have a quiz or a test, you all, that's a good thing. Sighs are good things because when you sigh, what you're doing, you're hyperinflating those microatelectic alveoli. And so when a patient is recuperating from thoracic surgery or abdominal surgery, they have a tendency not to want to inhale or breathe as deep as they should, or even women who've had C-sections. It sounds cruel, but they make them get up and walk within 12 hours. Why? Because they want to prevent atelectasis, and they don't want those lungs to collapse, and they're trying to help prevent pneumonia. Make sense? Mm-hmm. All right. So, So we want to make sure they have airway clearance of secretions, a productive cough if possible, and we want to have bronchial smooth dilation. Good. Okay. Did I see your hand up? Yes, ma'am. I'm sorry.
That's okay. No, so patients with COPD, they don't usually have, as a manifestation of the disease, a patent airway because they're constantly creating secretions.
Not all of them.
Okay.
COPD is a combination of two diseases. Mm-hmm. It's emphysema and chronic bronchitis. Mm-hmm. Emphysematous patients themselves, they don't have secretions. Chronic bronchitis patients do. Okay. So it depends whether it's a good day or bad day. I hate to put it like that, right. But some will, some won't. Now, those that smoke will.
Gotcha.
Yeah. Okay. All right. So how do we get distribution of inhaled aerosols? Well, remember I told you that the oral cavity, or the mouth, is shared by two systems. First, we think we eat, digestive system, right? Mm-hmm. But it's also shared by the respiratory system. Yes? All right. Yeah. So even though, I probably should have had it flipped, even though we're administered a drug for the inhaled portion, some does go to the stomach. Some will go to the stomach. And this is why we have to make sure that we're providing adequate instructions. So what happens on inspiration? What's going on inspiration? Anybody?
Air is entering the nose.
Air is entering the nose, which the nose is the preferred method of breathing. And so we're inhaling. And the only thing we do on inspiration is inhale room air, right? Room air. Or oxygen, whatever it may be. Okay, what happens on expiration?
Expel CO2.
Okay, we expel CO2, and what else? What's the function of the epiglottis?
For aspiration.
Okay, so what happens on expiration? Other than exhaling CO2, you are correct.
It closes.
What else happens on expiration? When do we talk? When do we eat? When do we swallow food?
We open our mouths. I would swallow.
So when does the epiglottis close? We talk, we cry, we swallow, liquid, food, we all on expiration, right? The only thing going on during inspiration is you inhaling air in your lungs. Cry, yell, scream, holler, swallow liquid, swallow food, all done on expiration. And all this time you thought your mother was telling you because of etiquette-ness, don't talk with your mouth full. If you talk with your mouth full, you might get some food that slipped down into that right mainstem bronchus on inspiration. So the function of the epiglottis is to close off the lower airway on expiration so you can swallow food and liquid and talk and cry and scream and holler and yell. How about that? But nevertheless, because of that, I was going somewhere with this. Nevertheless, there is an oral portion that hits the stomach. And it hits the stomach because the patient has inhaled the drug on inspiration. But all of it doesn't necessarily get or is not necessarily deposited into the lower airway on inspiration. So just by nature of having an oral cavity and both the digestive system and respiratory system share the oral cavity, some of that drug is absorbed in the stomach. Does that make sense? And my point is it's absorbed not on inspiration. This is inspiration. It's absorbed on expiration. That was my point. So we do get some in our belly. Yes?
It's absorbed on expiration because there's still residual vapor.
Yep.
Residual mist, yes. Mm-hmm. Does that make sense?
Mm-hmm.
Okay. But the majority, actually the majority is not through inhalation, but it's enough locally where the drug is going to do what we want it to do. And remember, if someone is really in distress, when we administer a drug, after we administer the drug, they still may need the drug for the next 4 or 5 days. But don't think that that drug or the one time you had the opportunity to administer the drug that it wasn't effective. They still may be wheezing, but some of the wheezing should have been subsided. They may still have a respiratory rate greater than normal, but at least it should have slowed down, or they may tell you they feel a little better. Okay, so don't think that whatever you do is not effective. It just may take a couple of days for it to be completely effective. All right? Okay. Here's distribution of inhaled medication. Primarily, see what we wanted to do. We know it goes through the nose, the oropharynx, and the laryngeal pharynx. That's on inspiration. This happens on inspiration. But on expiration, what it does, it goes through the stomach, it goes through the liver, then it's metabolized, and here's urine. What is that urine? That fixed acid. Okay? I just want you to understand that. Some of it is distributed through the stomach because sometimes the mist is still in the patient's mouth on expiration and they don't exhale it. They'll swallow it because that's what occurs on expiration. We swallow liquid. We swallow food. We talk. We cry. We scream. We holler. All that is only done on expiration. The only thing going on inspiration is you inhaling room air or oxygen, whatever you may be inhaling. So inspiration is very important, but a lot is going on expiration. Does that make sense to you guys? Mm-hmm. All right. So some of it, of the drug, is inhaled through the stomach. But it's metabolized because pharmacokinetics, and it's excreted through the urine. All right, let's look on page, I had the page, LT ratio. What page is LT ratio? So you can see what I'm saying. I'm going to make it very simple for you in chapter 2. What page?
The diagram on 22. It starts on 21, the detail though.
No, that's not. Oh, I'm in the workbook, that's right.
22, 21, 22.
Yeah, here it is. Okay, it starts on page 21 at the bottom, LT availability, LT. lung availability versus total systemic availability is a ratio. Okay, I want to read the key point. I'm at the bottom of 21 in the exclamation mark. It says the sources of the total systemic level of a drug are quantified by the LT ratio. And the higher the ratio, the more systemic drug is from the lung. As a result, efficient drug delivery, high first pass metabolism, or both. So in other words, what this is saying, let's look at, turn to page table 26 on 22. Okay, table 26 on 22. Here's a drug, albuterol, and it's in an MDI form. Everybody see that? Mm-hmm. All right. Lung deposition, meaning how much of the drug is deposited into the lungs, and according to if the patient is instructed to take the drug correctly, it's 18.6%. And so the LT ratio is 0.36. I'm not expecting you to do any math. I'm not expecting you to do any math. And so the subject or the patient, it means that the patient has good coordination. And so my whole point of you just understanding this LT ratio, it says the higher the ratio, the more efficient or effective the aerosol drug is delivered to the respiratory tract. So what I want you to understand, why patient instruction is important. The better a patient can follow instructions and take a drug effectively, or correctly, I'll say correctly, yeah. Take the drug correctly, the better the drug is going to work for them. That's all I really want you to know. That's all this is saying. I'm not expecting you to do any math. They don't test you on this on your boards. But poor coordination, poor patient coordination. You have a patient who's semi-conscious, they can't do an MDI, they can't do DPI because patient has to initiate their own effort and take the drug. How many of you are taking MDIs or maybe family members on MDIs or aerosolized medication or DPI at home and you never received any instructions? There you go. So the LT ratio, perhaps you are doing it right now because you figured it out, or somebody eventually told you, but the LT ratio was poor initially when you started, even though you had it in your hand. When these kind of drugs, if they're not taken correctly, they're not as effective. Does that make sense? And that's all really I want you to know. The higher the ratio, meaning the formula, lung dose divided by lung dose and GI dose, because some does go to the stomach. But the higher the ratio, the more effective the drug is in the lungs. So we're going to believe as respiratory therapists, we're going to give patients super instructions. And so how do we give super instructions? I don't care if the patient doesn't speak English. That's no reason for you not to communicate. This is when you have to become animated. And anything you expect the patient to do, you should be able to do it. You've got to show them how. Okay? And then after you show them how, you want them to show you how. And in the process of showing you how, if they speak English, you want them to communicate. Okay, so you're testing them. What are you taking it? Show me how you're going to take it. And why do you take it? How often do you take it? Now show me that you know how to take this medication. And if they're incorrect, you show them how they're incorrect and correct their wrongs and make them right. It's very, very important that we provide correct patient instruction. Okay? You may have a patient come in a hospital, been on a particular drug for 10 years, and they say, you know, my doctor told me to take this butyr something, and you say, albuterol, yeah, what's that for? And then, you know, you can't go out of the sympathomimetic and beta-2 agonist and adrenergic. You can't talk that way, but you've got to be able to tell them how to take that drug. Ask them, show me how you take this drug. It was so funny. I went to my physician. She was out of town, so her partner saw me. And it was one time when I was wheezing or whatever, and he said, Kathy, show me how you take your MDI. I bust out laughing, and I started wheezing again. And he said, what's so funny? I said, I'll show you. And it was like, this is what I teach, and he laughed too. But he asked me, and I knew then, which I believed anyway, he was a good physician, because he was concerned, was I taking my MDI correctly? Now, I've had asthma, and I'm in my 50s, and he's asking me to show how to take an MDI, but he was concerned. So it's important for you as therapists to know how to take these drugs and practice, and then you can demonstrate it to your patients, okay? So again, you got to have these kind of personalities, because everybody is not going to be cooperative. You're going to have cantankerous patients, and you've got to make up in your mind it's a challenge. I would love the patients that refuse their treatments. So my mission for today was to get them to take their treatments. And I can do it. And I'm not a charmer. I am not a charmer. You all know that. I'm not a charmer. But I could do it. And they just love me. So you got to make up in your mind, if you're that kind of therapist, you can do it. So that's really all I want you to know about the LT ratio. The more effective you can instruct a patient to take a drug correctly, the more effective and efficient it's going to be in the lung. Okay. Now it's inhaled in the, some is inhaled in the stomach. Are they experiencing bronchoconstriction in the stomach?
No.
That drug is just going to be metabolized and excreted through the urine. That's all this is saying. That's all I want you to know.
So if the kidneys release fixed acid excretion, then the lungs, that's not a fixed acid.
It's carbon dioxide in the form of a gas. A fixed acid is generally liquid. CO2 is a gas. It's still an acid, but just in a different form. Make sense? Okay. All right. I've gone through this, but still I want to go through it again. Agonist and antagonist. Agonist is a drug or chemical that binds to a corresponding receptor, initiates a cellular response. So basically, when we talk about agonist, we say alpha adrenergic agonist, beta 1 agonist, or beta 2 agonist. Just know what that agonist means. Agonist means we're going to administer a drug to stimulate a response. And so we say beta 2 agonist. That's synonymous term for bronchodilator. Okay, we want to stimulate a response. And so what drug can do all three of these? Epinephrine has all three. There's another drug that I gave you, racemic epinephrine.
Yeah.
It can do all three, but it's 50% less potent. So we probably use the racemic epinephrine for children. Not to say that we don't use it for adults, but most of the time we'll use racemic epinephrine for children and epi for the adults. Does that make sense? Agonist. Agonist means we want to produce an effect at cellular level. What effect? Alpha, beta 1 or beta 2, and particularly for our drugs, beta 2. Any questions with that? Okay, antagonist. Against, block, stop, inhibit. You choose your word. Drug or chemical that is able to bind to a receptor but causes no response. Inhibits or blocks the agonist, like a beta blocker. Some of you, just a few of you, got that wrong on the quiz. A beta blocker is still part of the sympathetic nervous system, because I see beta. It's still part of the sympathetic nervous system. It's just blocking the effect of the sympathetic nervous system. So a beta blocker is not part of the parasympatholytic or parasympathomitic family. It is not. Okay? But let's look at this word. Tying all this in, because when we get to these drugs, I won't race through them, but we can get through them a little faster. Okay, beta blocker. We just learned, or you know, some of you got we know this is part of the SNS, right?
Yes.
Because it's blocking the effect of the beta receptor. Now, what's this word? Anticholinergic.
Blocking TNS receptors, right?
Right. This is blocking PNS. This is blocking PNS. Or it could be called what? Parasympatholytic.
Colytic.
Good. It's still part of the parasympathetic nervous system, but it's blocking it. So it blocks the release of acetylcholine. Make sense? And this drug, or this classification of drugs, this classification of drugs are synergistic to our beta 2 drugs, right? Right? So don't get this confused. So I asked on the quiz about number 2, I believe it was, beta blocker. Some of you put that it was PNS. It is not PNS. It's still the sympathetic nervous system. It's just blocking. All right? And so if we see parasympatholytic, or synonymous term anticholinergic, it's still part of the parasympathetic nervous system, but it's blocking the messenger acetylcholine. Got that? All right, any questions? So let me say this. Is this statement true? A beta 2 agonist and an anticholinergic antagonist are synergistic. Yes, that's true. A beta 2 agonist and an anticholinergic antagonist are synergistic. Everybody got that? Okay. Antagonists are synergistic. So a beta 2 agonist is causing bronchodilation. The anticholinergic antagonist is blocking the effect of acetylcholine. And if we block the effect of acetylcholine, we can have the increased 3,5-AMP effect longer. Make sense? All right. Do I need to say that again? Yes. Okay. A beta 2 agonist, write it down. A beta 2 agonist and an anticholinergic antagonist are synergistic. Got it? Any questions with that? The beta 2 agonist is what part of the autonomic nervous system?
SNS.
SNS. The anticholinergic antagonist is what part of the autonomic nervous system?
PNS.
So in this case, they're working together. Okay? One is increasing 3,5-AMP, and the other one is decreasing 3,5-GMP. Cool beans. They work together. We have bronchodilation longer. Make sense? At cellular level. All right. And the last thing that some of these we've gone through, but I want to reiterate. Synergism, the effect of 2 drugs is greater than the sum of the separate effect of the drugs. Do anticholinergics work solely on asthmatics? Because they can't reverse bronchospasms. They can't cause bronchodilation, can they?
No.
So what's our first choice for the asthmatic? The beta 2, as well as oxygen, right? All right. And then if we find that if we find the beta 2 agonists are not responding, or the patient doesn't respond to the drug like they should, then we give the anticholinergic drug. And the asthmatic probably will respond. Let me tell you who won't. That COPD patient. They're the ones that will probably go home with the beta 2 agonist and the anticholinergic drug, because they've got a chronic condition, and they may take beta 2 agonists for a while and cool beans, but they keep smoking. and they keep smoking, and then the airways are just not going to respond to the beta-2 agonist. So they could use a drug like Combivent, which is a combination of a beta-2 agonist and an anticholinergic. Got it? So here you go. That's synergism. Idiosyncratic effect, opposite unusual. Sometimes we do things, and when I say we, I just don't mean therapists, I mean medicine. We do things, and statistics show, data will show 1 million people. It's a wonderful thing to do. That 1,000,001, all it takes is one, will have some kind of complications behind a drug. And next semester when we talk about pathophysiology, I'll give you more examples. But idiosyncratic, meaning that we gave a drug for one intention and it did the exact opposite. There are some drugs, once in a while, we know it's a potent beta-2 agonist. We give it to a patient and they start wheezing worse. That's an idiosyncratic effect. It wasn't that we didn't give the right drug. It wasn't that we didn't know what the drug did. But for this particular individual, it just did not work. It's not effective. Okay? Hypersensitivity, you know what that is. All right? Drug tolerance, decreasing intensity of drug response over time. So let's go back to the COPD patient. They've been taking a beta-2 agonist for 10 years, which is wonderful, but every now and then they'll slip and they'll give them a couple of cigarettes every day. And it's going to catch up with them, and then now maybe it's 10 years later, maybe in 5 years later, and the beta-2 agonist alone is not effective. So now then the physician or we will recommend that they have Combivent, Respiratory, or just throw in, I shouldn't say that like that, but they need an anticholinergic drug as well because they have developed a tolerance to the beta-2 agonist. But it's really not their system, it's because they're continuously smoking. Make sense? All right. I'm trying to make it relative to respiratory care. Tachyphylaxis, rapid decrease in a responsiveness to a drug, meaning that we've taken a drug, anybody's taken a drug, and it's been effective. But for this particular time, it's not working at all. It could be because the patient is on other medication, or it could be that maybe the liver is not functioning. It could be a lot of reasons a person develops tachyphylaxis. You need to know this term because you'll have patients in intensive care unit on a mechanical ventilator because of tachyphylaxis and the lungs will shut down. Okay. Yes, ma'am.
In respiratory care, if we say synergistic drug, that means it's always working PNS and SNS, like one drug is working on SNS and one is working PNS, or?
In the examples that I've given you,
Yeah.
But no, there's other drugs that we can administer synergistically with the SNS, the beta-2 agonist, but it's not working on the parasympathetic nervous system. It's coming through another door.
Okay,
So I've given you front door, which are direct. I've given you back door. I haven't given you side door yet. Okay. Side door doesn't have anything to do with
I was
yeah.
just asking for the respiratory care only, that, I mean, the drugs we are using.
Not all,
Not
no.
all of them. Only,
No,
yeah, the
you
one
got
that's
front door, back door, and I haven't
Side
got
door.
to side door yet.
Because you can have like two SNS drugs working together to affect.
If you have two SNS, it would
They
be
could
front door.
synergistic, right? But
That's-
it could be synergistic because they're working together to get a result? or no?
Very seldom will we do that.
Okay,
Because the patient would, it would be too much on their
Too
heart.
much. Yeah.
okay.
Yeah. All right.
So in other words, one was always, more than likely, one's going to be SNS, and the other one's going to, or one's going to be AMP, the other one's going to be GMP.
If that's what you're administering, we have side door drugs that don't have anything to do with
Oh,
PNS.
come on, what is that? Because, I mean, just a little bit.
Theophylline.
All right.
I gave it to you, theophylline. It's a phosphodiesterase inhibitor. Is that helping you?
No, but I just wanted to know.
When I get ready to give you the drugs, I'll give them to you. I don't want to overwhelm you.
Yeah, she really did.
I answered your question, right?
I don't think your
Yes,
balance
you
was
did.
full something there.
All right. Okay, So on Thursday, you will have another quiz, and the quiz is going to entail what you've learned, P&S, S&S. Autumn, before we leave, I want to correct this. Another quiz on Thursday is going to entail P&S, S&S. I don't have the LT ratio on there, but I'm going to have some of these terms that we went over today. Some of them you're quite familiar with, right? Okay. All through the program, you're going to have beta agonist, anticholinergic. We're going to build upon our vocabulary and your understanding of drugs. But for right now, you got the front door bronchodilator, which is a direct effect on the SNS. And no, we never administer 2 beta-2 agonist drugs together. Never. Never. And then you got the backdoor drugs, which are the anticholinergic. You got more classifications coming, but I want to make sure you got this first. Okay? Now, Kyle asked, so it's not theophylline, it's theophylline. And it's going to be one of the drugs that I give you. I just haven't given it to you yet. Kathy Miller's term is a side door bronchodilator. You know, you can go through the front door, you can go through the back door, you can go through the side door, right? And then if you have, what do they call them? What leads out to the, what's the sliding door? What, patio? You have sliding doors too, right? It's more than one way to get in a house without breaking in through a window, right? All right. So we'll take quiz 3 on Thursday, but before you take the quiz, if you have any questions, I will be able to, I will be more than happy to answer them for you. No, anytime I give you a quiz, that's for yours to keep. All the quizzes, please hang on to, because your final exam in here is cumulative. It's cumulative. It's about 200 points, and so I'm trying to decide how many questions I'm going to do, but I'll figure it out. It will all be multiple choice, though. I can tell you that. Yes, ma'am?
So the quiz on Thursday, you didn't say it, but you said it earlier, is also going to include ABGs?
No, the quiz tomorrow includes ABGs, not the quiz on Thursday.
Okay.
The quiz on Thursday, and we're just going to stick with pharmacology. 3, 5A, and P. Overall, I'm satisfied overall, but it's still a few of you. Some of you did come to see me, which is great, but it's still a few of you. I don't know if you were nervous because you took a quiz or what. But if you need help, because like I said, I don't want to keep going further and you're losing out, you're losing out. If you need help, get help. Okay? And again, I'm not minimizing anything in the textbook. But for some of you, you read the text, it's going to confuse you. So if you need help, help each other. Come see me, whatever you want to do. Okay? Okay, I'll see you tomorrow. Tomorrow I will answer any question. Tonight, what are you going to study? Blood gases?
Yes, ma'am.
And central chemoreceptors and peripheral chemoreceptors, right?
Okay.
And you need to be able to explain to me both of those functions in your own way. I'm telling you what's on the quiz. Blood gases, central chemoreceptors, peripheral chemoreceptors, and the indications for oxygen, and the 4 different types of hypoxemia.
That was your last question.
Yeah, that was my email. It's in your email.
Oh,
I'm telling you specifically what's on the quiz. I wrote the quiz based on the email that I sent you. Yeah.
I'm not sure if it is on the